Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbury-Cullen, Andy Godwin, Andy Jagoda, Ginnia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. An introduction regarding the use of CT studies in stroke patients. Who is the patient population with whom we will be working in the emergency department? First, you'd like to know what types of stroke patients will need these types of testing. And in fact, it is patients with both anterior and posterior circulation ischemic stroke symptoms. Those with anterior stroke symptoms most commonly involve some abnormality or clot in the middle cerebral artery, and those with posterior stroke symptoms will involve some problem with the vertebral basilar system. When we talk about anterior circulation stroke, we're talking about anterior portions of the circle of Willis and blood flow disruption in those areas. You can see on the left there's a large middle cerebral artery seen on CT, and on the right you can see there's an MCA occlusion noted on CT angiography in the yellow circle. When we talk about posterior circulation stroke, we talk about areas that the posterior portion of the circle of Willis supplies and the vertebral basilar system. This includes the thalamus, the occipital lobes, the brainstem, including the midbrain, pons, and medulla, the cerebellum, and other cortical regions in the posterior portion of the brain. So what are our treatment imperatives and standards when utilizing CT testing in stroke patients? So what's our treatment imperative or imperatives? We'd like to rapidly diagnose acute ischemic stroke. We'd like to establish early blood flow restoration to the ischemic penumbra, that area that will benefit from restored circulation. We'd like to minimize the size of the stroke core infarct. We'd like to optimize our 90-day outcome on modified Rankin scale, that is patients with either 0 or 1 who are independent. And we'd like to minimize complications, morbidity, and mortality related to the stroke. So what is our stroke treatment standard? Well, the most commonly understood and well-practiced standard is the use of IV thrombolytic therapy up to 4.5 hours following the stroke onset or ictus. Here is a graphical representation of when the odds of treatment benefit approaches 1, meaning no patient outcome is likely, no benefit is likely to occur with the use of IV thrombolytic therapy. This occurs, the 95% confidence interval around this graph crosses 1 at 270 minutes or 4.5 hours, hence the 4.5 hour therapy marker for IV thrombolytic therapy. What are the key clinical questions and diagnostics that we will use and help us to guide our thinking as we attempt to diagnose and treat stroke patients? First, we'd like to know whether patients in particular can be identified that require acute IV thrombolytic therapy, have an identifiable vascular lesion, have a large vessel occlusion or LVO, should receive endovascular treatment or EVT, and who may benefit from some type of mechanical clot removal or intraarterial thrombolytics. We'd also like to identify patients who are likely to have a complicated hospital course, those who are likely to have a poor long-term outcome and therefore may be best treated without aggressive acute therapies. Now, with regard to stroke patient diagnostics, you ask the question, what tests are we talking about? Well, of course, we need to obtain vital signs, a pulse ox, glucose, a rapid history and physical exam. We'd like to understand when the stroke ictus or onset time occurred. We'd like to do a functional neurological exam. In other words, can the patient walk, talk, see, move their extremities? Are there areas of neglect, or is there aphasia related to some speech abnormality? We'd like to be able to estimate the NIH stroke scale or calculate it if trained in doing so. We will obtain an EKG to make sure there isn't a concomitant acute myocardial infarction. And most importantly, what we'll discuss today is the use of non-contrast CT and CCT and the CT studies listed here. We understand that MRA and other MR perfusion studies are also an option, but we also understand that most often these tests are not used acutely because of the time requirements, especially related to the need for acute thrombolytic therapy. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.